Welcome to LPN LaunchPad's quick review of motor function and coordination assessments. Using a systematic head to toe approach, we will explore methods to evaluate muscle strength and coordination and understand common functional limitations. This assessment evaluates muscle strength, coordination, and functional limitations. It employs a systematic head to toe approach to ensure a comprehensive evaluation. When assessing strength in the head, face, and neck, begin with facial strength tests by asking the patient to raise their eyebrows, close their eyes tightly, puff their cheeks, and smile. For neck strength, instruct the patient to turn their head against resistance and to shrug their shoulders against resistance to identify any deficits in cranial nerve function and muscular control. Assess the upper extremities by evaluating shoulder strength with pushing and pulling against resistance, elbow strength by testing both biceps through elbow flexion and triceps through elbow extension against resistance, and grip strength by having the patient squeeze the nurse's fingers while comparing the left and right hand strength to gain insight into the functionality of muscles and nerves in the upper limbs. The nurse evaluates hip strength for the lower extremities by instructing the patient to lift each leg. At the same time, the nurse applies downward pressure, assesses knee strength by testing both knee flexion and extension against resistance, and evaluates ankle strength by testing dorsiflexion, lifting the foot upward, and plantar flexion, pushing the foot downward, against resistance to identify any deficits that could impact mobility. The muscle strength grading scale is as follows. 0 indicates no muscle contraction, 1 suggests a flicker of movement, 2 indicates movement only with the elimination of gravity, 3 indicates movement against gravity but without resistance, 4 indicates movement against some resistance, and 5 means full strength against resistance, which is considered normal. This scale is essential for documenting and communicating a patient's functional status. Ask the patient to perform the rapid alternating movements test by flipping their hands back and forth on their thighs and quickly touching each finger to their thumb. This test evaluates cerebellar function by assessing the patient's ability to perform smooth, rapid, and alternating movements. During the finger to nose test, instruct the patient to touch their nose. Then, the examiner's finger should be rapidly moved while the target finger is moved to different positions. This test is used to identify dysmetria, characterized by poor control over movement, such as overshooting or undershooting the target. For the heel to shin test, instruct the patient to run their heel down the opposite shin from the knee to the ankle, and then repeat the movement with both legs. This test indicates cerebellar ataxia, when coordinating the lower limb is difficult for the patient. During the gait and balance assessment, observe the patient's walking pattern for smoothness and steadiness. Perform a heel to toe walking, tandem gait test to assess balance and coordination, and include toe walking and heel walking tests to evaluate lower limb strength. These observations provide crucial information about the patient's overall motor function and stability. Common motor function deficits include ataxia, uncoordinated movements often indicative of cerebellar dysfunction, hemiparesis, weakness on one side of the body commonly seen in stroke patients, spasticity, increased muscle tone typically associated with upper motor neuron lesions, and flaccidity, decreased muscle tone often seen in lower motor neuron lesions. Understanding these deficits aids in forming a clear clinical picture. For motor function on the NCLEX, differentiate between upper motor neuron lesions, which typically cause spasticity and hyperreflexia, and lower motor neuron lesions, which result in flaccidity, hyporeflexia, and muscle atrophy. Master the muscle strength grading scale and prioritize assessment findings based on the severity of motor function deficits and their clinical implications. When studying coordination for the NCLEX, focus on memorizing key cerebellar tests such as rapid alternating movements, finger to nose, and heel to shin tests. Be prepared to identify abnormal gait patterns and understand their clinical significance. This knowledge is essential for clinical practice and exam success. Consider the following NCLEX question regarding motor function. Which assessment finding suggests an upper motor neuron lesion? A. Flaccid muscle tone. B. Decreased deep tendon reflexes. C. Spasticity with increased muscle tone. D. Muscle atrophy with fasciculations. The correct answer is C. Spasticity with increased muscle tone. Upper motor neuron lesions are typically characterized by spasticity and hyperreflexia, whereas lower motor neuron lesions are associated with flaccidity, hyporeflexia, and muscle atrophy. This distinction is critical in accurately identifying the type of lesion. Consider this coordination question. A patient cannot perform rapid alternating hand movements. What is this inability called? A. Dysmetria. B. Dysdiadochokinesia. C. Ataxia. D. Apraxia. The correct answer is B. Dysdiadochokinesia. Dysdiadochokinesia is defined as the inability to perform rapid alternating movements, whereas dysmetria refers to poor movement control characterized by overshooting or undershooting a target. Ataxia is a broader term that describes uncoordinated movement affecting gait and balance, and apraxia is the inability to perform learned movements. Consider the following scenario. A nurse assesses a patient's motor function by asking the patient to touch their nose and then touch the nurse's finger as quickly as possible. The patient overshoots the target and has difficulty controlling the movement. This finding is most indicative of A. Parkinson's disease, B. Cerebellar dysfunction, C. Myasthenia gravis, or D. Peripheral neuropathy. The correct answer is B. Cerebellar dysfunction. Overshooting the target and exhibiting poor movement control, which are manifestations of dysmetria, are hallmark signs of cerebellar dysfunction. Parkinson's disease is typically characterized by resting tremors and bradykinesia. Myasthenia gravis presents primarily with muscle weakness, and peripheral neuropathy generally affects sensory perception rather than fine motor coordination. Hey there, this is Brian. I am the creator of LPN LaunchPad. I want to say thank you for learning with us. In addition to these videos, I've created a series of free adaptive quizzes in ChatGPT. The link to this video's quiz will be listed in the description below. Help me keep this project alive by hitting the like and subscribe buttons.